Hello, my name is Adam Hoey, and I'm presenting today my final project for the Human Factors in AI course with Duke University. The project that I have selected today is the DC Health and Human Services Cross Connect program with AI case management. And so the summary here is essentially a data sharing program for DC agencies across health and human services, such as Child and Family Services, Department of Behavioral Services, Department of Human Services, as well as the police department and DC public schools. And the goal is to try to identify families and residents that are in need, that are in this hypothetical red zone, and to try to coordinate care to try to improve their life overall. And so what we're trying to do is move beyond the data sharing using spreadsheets and Excel and other manual tedious methods to try to improve services and to eventually implement predictive analytics. The users of the system with task analysis are the healthcare workers and the caseworkers. These are the people who are using the system and are actually building the teams and coordinating the care, as well as the program managers. And the members of the red team are residents of the city. So people who are homeless, troubled youth, people from troubled families, anybody that's going through a real rough patch. And so the task is to try to identify these people through some different types of data inputs, such as truancy reports and police reports and health reports and other types of reports that can kind of help to actually identify that people are in this troubled area and they need coordinated care. And so the goal here is essentially to reduce the time that it takes to find the people, to put them into the coordinated care program, to improve accuracy, to improve services, and to reduce the tedious manual process of selecting and monitoring these people. And then the last benefit would be to try to predict people through data analysis and machine learning who may be gravitating towards being in the red zone in the future and to try to take action earlier. So what's the trigger? The trigger are the warning events that come up in the data through these different agencies in their reporting systems. And the action is collecting the data from different agencies into one repository where it can be analyzed instead of doing it with tools like Microsoft Excel or individual case tools that people are doing manually. And the decision is to identify the people who need to be added to the program or also removed from the program. Another decision factor would be to predict people who are in this yellow zone who may be candidates for the red zone in the future so that they can take the action to kind of give them service immediately to try to prevent them from getting worse. So the objective overall is to try to keep as many residents as possible from even entering the red zone in the first place. But if they're there, to be able to offer them coordinated care to kind of improve their quality of life. The user experience design and proposed solution, the users essentially can interact with the system using their case management systems and their CRM system. A tab screen might be able to show a filtered list of residents that are in the red team group, and the filter can also allow caseworkers to see residents who are predicted to be in the red team. As far as user inputs, the users and the caseworkers can be surveyed to try to explain what challenges they have in terms of trying to find people to put them into the red team and to manage the red team. They can also rate how the system is working. And then, of course, people that are actually on the red team should also be told about the data that's being collected, for what purpose it's being collected, how it's being viewed, how they can correct it, and how they can remove it. As far as transparency, the model should indicate which data sources are being used, what business rules are being used, what are the policies and case notes that were used to make the determination in the cases for people to be in the program. And then communicating uncertainty, the model should balance probabilistic and deterministic events, such as when and who should be predicted to be on the red team by a percentage. So it may not be that it's a yes or a no. It might be that certain people have a higher percentage need to be in the program than others, and that can allow a human caseworker or program manager to kind of make their own judgment using the tool. As far as privacy concerns, personal and sensitive information such as health, education, and financial data are big privacy concerns for the system, especially when the data is being shared across agencies and partners. So the sharing of the data across the agencies must be under legal contract with data sharing agreements across the entities, and the users of those systems should certainly not be using third-party AI communication tools with any of the PII data. As far as applicable privacy laws, the California Consumer Privacy Act, CCPA, would probably be the safest one to use because it's the most comprehensive. And of course, HIPAA, Health Insurance Portability and Accountability Act, and FERPA, the Family Education Rights and Privacy Act, would apply to the program. The law requires that the system meet compliance guidelines for security safeguards to protect all the data, report breaches, ensure that a designated privacy officer exists, and that audits are performed. Residents, consumers, and patients should be able to see their data and make changes to remove it. Finally, with ethical considerations, there are potential sources of bias. A area of bias is in the form of representational harm, where certain people may be stereotyped and recommended for the red team based on their race, their age, their income, or where they live in the city. Allocative harm may occur when people who need the service are weighted lower and don't get into the program because of their demographics. As far as meeting ethical codes of fairness, accountability, and transparency, the system and data models will be curated to reduce red team recommendations to residents traditionally living in low-income neighborhoods based on race, gender, and color. So I'm just making sure that the historical data isn't driving what the outcome should be in the future. As far as accountability, the system should identify who's responsible and what rules the models are based on and how to see their data and to be able to ask for recourse if they think something is wrong. As far as transparency, caseworkers and residents should have the ability to know what data is being used by the system and how conceptually the model is driving outcomes. Feature use and weight, as well as simplified approximations and counterfactual explanations showing how alternative events could improve their position would also be recommended. As far as mitigating these ethical issues, the system managers can implement regular use of data sheets, ethical checklists, and ethical pre-mortems when implementing new versions of the software. Thank you very much.